Welcome again to another edition of the Osteopathic Lyceum podcast. We're going to talk about a few things here today. And one of the reasons we're going to do it the way that we're going to do it is mostly in response to the variable regulation in a lot of areas. So, if we consider things like nutrition and pharmacology within the practice of osteopathic manual therapy, we have to understand that osteopathic manual therapy is practiced in a lot of different jurisdictions with a lot of different rules. So the essential components of understanding nutrition and understanding pharmacology for an osteopathic manual practitioner should be considered from what is available everywhere, not necessarily what is available in a specific jurisdiction. Because if you look at that specific jurisdiction that has, say, a much larger scope, then to ask all of the jurisdictions to correspond with that or say line up with that is inappropriate because the practitioners will have information that they're not legally allowed to utilize. Now, at no level would I make the argument that it is not valuable to understand the basic physiology for any human being or how both nutrition and pharmacology can interface with that. I would argue that it's valuable to understand. However, for the osteopathic manual practitioner, it is not necessarily valuable to be utilized in a patient interaction. The thing that is consistent, regardless of jurisdiction, with osteopathic manual therapy is hands-on assessment and hands-on intervention, not pharmacological assessment or intervention, and not nutritional assessment or intervention. So what I'm going to do really quickly is pull up the WHO document for benchmarks for training in osteopathy. Again, it's 2010 document. It may be due for an update. Keep in mind that I have spoken about this document before and that it is not truly a WHO document. It's a document aimed at the region of Lombardy in Italy. Was essentially spearheaded by the regional government of Lombardy in Italy. So keep that part in mind. I'm going to pull this up. This is a document that is considered standard or a standard. It has no binding authority. It has no policy implementation teeth. However, many jurisdictions will consider it a standard, despite the reality that it does not appropriately respond to the variation jurisdictions. It is appropriate to the region of Lombardy in Italy. It is not necessarily appropriate to Ontario in Canada. It is not necessarily appropriate to Nova Scotia or Alberta in Canada. It's definitely not appropriate to America because American osteopathic practitioners are doctors. They have unlimited medical licenses. Therefore, they would actually likely need more than what's prescribed in the document. So I'm going to pull this up and we'll go through some other documents to show kind of the angle that we're taking, as well as to speak about the details that we'll speak about. So I will pull this up first. It lets me. Okay. Here we go. I'm going to, for those who can see this and not those who are simply listening, I'm going to simply resize my video here. And because of the way that I have the camera set up, I have to look off to the side as I read. So one of the things, specifically if we start with nutrition, that we want to understand is that one of the reasons that nutrition in current thoughts on osteopathy is going to be meaningful is primarily because of something called the bioenergetic structure function model. Now, the bioenergetic structure function model could very easily be considered something that was woo-woo if you just looked at the title. However, what it's really talking about is essentially homeostasis or allostasis. Allostasis being more so the stressors or the impact of stressors, where homeostasis is the ability to be adaptable around a relative midpoint for function, right? So the bioenergetic, and I'll read this from the WHO document. This is in the WHO document, and then I'll move around to show you some other things within the WHO document. So the bioenergetic structure function model, or sorry, rather, the bioenergetic model recognizes that the body seeks to maintain a balance between energy production, distribution, and expenditure. Maintaining this balance aids the body in its ability to adapt to various stressors, immunological, nutritional, psychological, etc. This model applies therapeutic approaches, including osteopathic manipulative techniques, to address factors which have the potential to deregulate the production, distribution, or expenditure of energy. So it's homeostasis with respect to nutrient availability within the body. There's a few models that would explain this relatively well that have nothing to do with osteopathy and don't necessarily require a huge in-depth understanding. As far as energy balance, so you need to talk about macronutrients. So some places that you look at will say there's 3 macronutrients: proteins, fats, and carbohydrates. Some places will tell you that there are 4, with water being the extra. Water is essential for human life, as is protein, carbohydrates, and fats. Now, your energy balance is going to be predicted by the intake of protein, carbohydrates, and fats. Fats having more energy available as it passes through things like the Krebs cycle, carbohydrates having a little bit less, and proteins having less, proteins requiring more energy to be liberated to turn into ATP. Should that be the case, if proteins are being used as a strong substrate, you're probably looking at malnutrition and muscle wasting. That is very unlikely that most osteopathic practitioners who have a scheduled practice, aka people call or get in contact with practitioner and make an appointment, you are very unlikely to see people in states of malnutrition. However, some osteopathic practitioners will do outreach work. They will go to places that will put them into unscheduled practices in places in the world that they are more likely to see malnutrition. Malnutrition is essentially going to be highlighted by things such as low energy, low functionality, cognitive changes you would see with issues answering questions, memory, verbal ability, things of that nature. So it's unlikely that osteopathic practitioners are going to note malnutrition. However, under certain circumstances, they might. And if they do, that is not their place to deal with. That is more likely a referral to another practitioner. The energy balance concept is best described by calories in and calories out. So the energy balance, so production, distribution, expenditure. The distribution is mostly talking about the vascular system and the lymphatic system, which you could call the vascular system. And the interface there for osteopathic manual practitioners is going to be identifying movement restrictions, especially in soft tissues, that would add or increase pressure to low pressure vessels, such as lymphatic vessels and veins. So if you have a problem with a soft tissue adding pressure to a region, you can make the inference that you might have a delivery or distribution problem for fluids. If that's the case, then maybe you can start to infer, not prove by any stretch of the imagination, that there could be a problem there. Historically, you'd hear in osteopathic, or you'd read in osteopathic literature, the term trophicity, or say the characteristics of the tissue or the health of the tissue. And this would then relate. But as you note, I'm telling you that as far as, say, distribution of energy, the osteopathic intervention is going to be assessing motion characteristics of gross motion as well as soft tissues, under the assumption that added pressure is going to impede the distribution of fluids. So it's still a movement-based assessment and a movement-based treatment, not a nutritional-based assessment or treatment. So you can make a lot of inferences, you can build a lot of clinical pictures through assumptions and inferences, but you can't prove them. At the end of the day, though, osteopathic practitioners are still going to come back to movement-based assessments and treatments. Now, to touch back on the calories in versus calories out model, if you take in more calories than you expend through basal metabolic rate, which has a few components, as well as general daily activity. If you take in more calories than you expend, you generally suspect that the patient or the individual will store energy, or they will have excess energy taken in, which usually is going to be identifiable in measurements of weight, right? If somebody takes in less calories than they expend, so they expend more than they take in, you can generally note that they would be likely at an energy deficit. Usually your proxy measure or your quick measure for that would be a drop in weight. So a drop in weight is often in the short term more dangerous for health, especially if it's dramatic, than an increase in weight. An increase in weight tends to have longer term possible health issues with varying conditions that don't absolutely need to be named or discussed deeply. However, your calories in versus calories out model is a really nice rough model with respect to understanding the bioenergetic structure function model. The intervention that the bioenergetic structure function model is going to point to for osteopathic manual practitioners, as I've said, and this is redundant on purpose, is still going to be movement-based assessment and movement-based treatment. Okay, so what I'm going to do is look through nutrition now. No, that's not working the way I want. There we go. So nutrition within the WHO document is mentioned a few times. Oh, no, that's not what I want. I pushed the wrong button. There we go. So as far as the suggestion for curricular count or curricular hours for nutrition, there's 40 basic nutrition hours, 6 nutrition and clinical dietetics, and then 6 more. So that is 52 total hours of nutrition as suggested for the specific context of the region of Lombardy, however, adopted by the WHO and utilized as a standard by a bunch of other jurisdictions or a bunch of other countries, such that they, when looking at osteopathic education, they're going to use this. Now, that's totally fine. I totally understand. I will say that I do not believe that that is appropriate in most jurisdictions. Okay, so I also want to look at this document and just let you see pharmacology, if I can type properly, which I did not apparently. Right, so 21 hours in pharmacology, another 40 in pharmacology, so that's 61. Yeah, so 61 hours in pharmacology, more or less. Now, because osteopathic practitioners almost everywhere in the world have no ability to interface with pharmacy or to suggest that a patient use pharmaceuticals or tell a patient that they shouldn't use pharmaceuticals, I think there's some redundancy there. Now, I'm not going to say that there's no value in understanding it. I've already suggested that there is a value in understanding it. However, the primary understanding should be that you're going to have patients who are going to be using pharmaceuticals. Now, in most scheduled osteopathic practices, in most places in the world, the primary complaint is going to be some form of discomfort. So you're most likely seeing people utilize pharmaceuticals that are primarily related to pain state. And often what that's going to be is a non-steroidal anti-inflammatory drug. If it's prescribed by a physician, it may be a steroidal anti-inflammatory drug. You can look these up and try to figure them out. Your common ones are going to be things like ibuprofen, acetaminophen, acetylsalicylic acid, right? So Advil, aspirin, Tylenol, things of that nature. There are some others that you will see commonly in many jurisdictions, but not everywhere. The pharmaceutical rules of a lot of places are different, such that you won't see some drugs in one jurisdiction that you will see in another. The other thing to be aware of is you should collect information from your patients on the pharmaceuticals that they're utilizing so that you can then go through and consider whether or not any of those drugs would be contraindication. So as you can see here, anything with respect to anticoagulants, right? So something that is going to stop blood clotting, such that if you were to mobilize a patient and if there were to be some form of internal disruption to a blood vessel and they cannot clot, then they could have an internal bleed that could become a major problem. So anybody's on any anticoagulants, you need to know that. Anything with respect to pharmaceuticals that are going to affect connective tissues. So corticosteroids, cortisone shots, at the clinical level, they can thin soft tissues, they can thin connective tissues, so they can make them more susceptible to disruption. So you need to do that. And if you are not sharp with pharmaceuticals and their common uses and their common outcomes, then it would be very intelligent when you see a pharmaceutical to look it up and look up the common outcomes, right? So what it's for, what it will do, what it will offer, what kind of side effects may be there. and you can utilize that to further understand if it is safe to treat a patient or if it is unsafe. So that's the WHO document. Now I'm going to do something here just so I can move to another this is not doing what I wanted it to do. To move to another window here. One of the reasons that I want to talk to this point of especially in Ontario or in Canada generally, of avoiding interfacing with patients with respect to nutrition and pharmacology as an osteopathic practitioner is the Regulated Health Professionals Act or Regulated Health Practices Act. I can't remember which the P is practices or professions for RHPA, but the RHPA has controlled acts. If you are not certified, if you are not legally allowed to engage in certain healthcare activities, that means you are subject to the criminal code. So osteopathic practitioners in Ontario and in Canada generally are not regulated professionals, such that any interface that you have that is not based on hands-on assessment and treatment of movement is in contravention of controlled acts for the most part. Now, this is going to differ province to province, but I can speak to Ontario specifically. So the first controlled act is communicating to the individual his or her personal representative a diagnosis identifying a disease or disorder as the cause of symptoms of the individual in circumstances in which it is reasonably foreseeable that the individual or his or her personal representative will rely on the diagnosis. Now, there is some leeway there. You can communicate what you believe to be a clinical impression. You can say, based on the information that I'm identifying, I have concern that some things may be going on that are dangerous to you. I think you should see your physician and ask them to look at these things. So you can do that as an osteopathic practitioner. However, you cannot say, I think you're low in vitamin D. I think you need more protein. I think you are eating too much fat. Or I think you should go on a ketogenic diet so that you have high fat, which means that you are preferentially going to burn fat as an energy substrate, because that's what the bioenergetic structure function model would suggest is a good idea in your particular case. You cannot do that. But you can say, hey, I think one of the reasons that we're having a little bit more of an issue getting your condition to come around or getting your sensations to come around through treatment. So the treatment is changing motion appropriately. I'm identifying restricted motion. I'm treating restricted motion. I'm reassessing that restricted motion is changing. However, you still have this consistent complaint. It might be worth circling back with your physician to consider other things. So the physician can then do other diagnostics. You can say, hey, there might be something that you're doing repetitively that's causing this. So you might want to consider things like inflammation, which can be mediated by diet. So if you see a patient who is not getting better, despite your assessment and reassessment suggesting that on the mechanical level they're changing appropriately, you can then begin to infer that there might be something habitual, and that habit could be food. So you can then refer out to a physician or to a dietitian, possibly a naturopathic doctor, because naturopathic doctors are allowed to provide nutritional assessment and counseling and treatment. You can refer out. But what you would have to see as an osteopathic practitioner is that you are assessing and finding restriction, treating the restriction, and that the restriction is consistently changing and staying changed, such that subsequent visits, the mechanical dysfunction is continuously improving. However, the patient complaint isn't changing. That means it is outside of, as far as the sensation that the patient is providing a complaint about, that is outside of the mechanical realm. Therefore, it may be habitual. Therefore, it may be inflammation. Therefore, it may be dietary. So you would need to refer out to that for that, because with respect to controlled acts, as an osteopathic practitioner, you are unregulated and not allowed to touch on these things. Now, that would hold true for pharmacology as well. As far as pharmacology is concerned, the prescribing physician is the only person who is allowed to provide counsel that the patient should come off of a pharmaceutical that has been prescribed. The patient does have autonomy and is able to choose what they want to do in relation to a prescribed medication. But that's the patient's autonomy, and that is covered by ethics. Whereas nobody else should be giving counsel to a patient that they should change or a pharmaceutical. You can, in conversation with the patient, when the patient is complaining about the medicine, provide a suggestion that they should circle back with their physician and talk to them about it and report the issues that they believe they're having with it. So the physician who prescribed the medication can possibly reconsider or provide some other counsel, but you can't talk to them about it. So the concept that I'm really trying to drive home is that in most jurisdictions, osteopathic practitioners, despite training, should not be interacting with specific assessment or recommendation with respect to nutrition or pharmacology. So the internal physiology is not something we should really be talking about unless it obviously and clearly relates to a very superficial movement restriction. So another thing that I'm going to attempt to do here, I'm going to switch the screen that I'm sharing so that we can see something from Foundations of Osteopathic Medicine. And where did we go? So Foundations of Osteopathic Medicine, which would be considered a standardized or a central and common, like a central and common resource on nutrition, or sorry, resource on osteopathic practice rather, not on nutrition, on osteopathic practice. What they do is they defer to nutrition pyramids. So they generally defer to nutrition guidelines within any jurisdiction that a practitioner may be working. So in Ontario, for myself, as an osteopathic practitioner, Foundations of Osteopathic Medicine would essentially say, look at the Canada Food Guide. That would be my primary source for information with respect to nutrition or nutritional insight that I would possibly share with a patient. However, because of the RHPA and the possibility that me providing nutritional insight to a patient could be misconstrued as a causative pathway for a dysfunction that a patient has, I really can't talk about it. You can have a decent amount of discussion around food pyramids in the positive or negative direction. I'm not going to have that, as I am not necessarily an expert who should be holding out on that. But as you can see, this is from Foundations of Osteopathic Medicine. This is the third edition. This is from 2012. Impact of illness on the individual and society. It says nutrition, talks about that. It says pick your pyramid, right? This pyramid is the USDA pyramid. So the one you're seeing on page 379 here on the screen is the USDA pyramid. There's the vegan food pyramid, things of that nature. So the advice essentially, or the conceptual advice or the abstract advice from Foundations of Osteopathic Medicine is that you defer to the food pyramid in your jurisdiction. So what it is saying is look to government regulators for your nutritional advice as an osteopathic practitioner. That's what it's more or less suggesting that you do. What I would say is that if you understand that malnutrition is the more dangerous short-term problem for patients in that they don't have enough of a nutrient, be it a macronutrient in protein, fats, or carbohydrates, or a micronutrient, as would be identified by varying subfunctions such as vision, such as energy. So vision being your carotenoids or your A vitamins and derivatives thereof, your B vitamins being for energy, your antioxidants, so your A, I believe, being one of them, vitamin C, vitamin E, being antioxidants, vitamin D being exceptionally important for calcium, magnesium being exceptionally important for calcium regulation, things of that nature. You can start to understand that and you would see essentially poor function somewhere as a possible indication of malnutrition or not enough of something. And then you would still have to refer out to a physician or so an MD, an ND, or a dietitian to do that work in most places to figure that out. So you can identify a sign of malnutrition as low function in a particular way. You can also identify excessive intake of calories. So this is where calories in, calories out, where you see excessive energy storage. Now, I'm saying it that way in order to be respectful, right? So excessive energy storage would usually be identifiable with higher amounts of adipose tissue. Now, that adipose tissue is almost, that you're going to be able to identify, is almost always going to be subcutaneous. So again, I'm trying to be respectful in saying that if you see energy excess, it's usually increased adipose tissue. Now, increased adipose tissue is not an immediate health risk. It can be a long-term health risk. So you're looking more at a chronic process. And most people have the capacity to interface with that through means of altered diet and altered exercise. So often increased exercise, not always, but often, and a change in dietary choices. That would be best mediated through interface with an MD, an ND, or a dietitian, not an osteopathic practitioner. And again, in most jurisdictions, you're not actually allowed as an osteopathic manual practitioner to interface with them as far as nutritional assessment or nutritional guidance. You would have to defer to the general guidelines of your jurisdictions. Some jurisdictions may not have nutritional guidelines. They may not have a food pyramid. They may have nothing, right? It depends on the particular place that you're practicing or that you're looking to practice. But when you defer to the nutritional guidelines of the jurisdiction, then you're playing within the bounds of the law, which is always smart. But your malnutrition is dangerous. Your excessive nutrition is far less dangerous. It may be chronically, however, most patients, should they choose, and one of the major challenges with with nutritional modification, be it for malnutrition or excessive nutrition, is actually issues of behavior modification. It is much more about behavior change with respect to nutrition than it is anything else. So the psychological aspects are there. And as an osteopathic manual practitioner, you are not supposed to be interfacing with the patient psychologically as far as attempting to have them change behavior around nutrition. That is not your role. At least if you're in Ontario, it's against the law for you. You are engaging in a protected act. But again, understanding that your macronutrients are important, your micronutrients are important, that a very fundamental understanding that many of your patients are going to be on pharmaceuticals and that you should collect that information from them and you should look those up to understand if there is any reason why external movement from a practitioner would cause problems due to the medication. That's a contraindication. So instead of osteopathic practitioners trying to get really deep about nutrition or trying to get really deep about pharmacology, what they should do is respect that it is not their area of expertise, regardless of their training in an osteopathic institution. Now, if they have training outside of that osteopathic institution, let's just say a naturopathic doctor is becoming an osteopathic practitioner, well, they're in a completely different boat. As long as they maintain their naturopathic regulatory status or their appropriate licensing status, they can do those things. If a registered dietitian is going to become an osteopathic practitioner, this is a completely different story. A medical doctor is going to become an osteopathic manual practitioner. This is a completely different story, as long as they keep up their licensure. But for the most part, osteopathic practitioners are not in a position, regardless of what training they received in osteopathic school, to be making pharmaceutical assessments, pharmaceutical interventions, pharmaceutical insight or guidance for patients, nor are they to be doing that with respect to nutrition. So we've very briefly, very superficially touched on things such as nutrition and the reality that you should defer to other professionals, or if somebody asks you anything directly, you can point them to resources, and the safe resources would be your local food pyramid or whatever food guide exists within your jurisdiction. But other than that, you should really not play in those realms. It is not safe. It is often not legal. You don't have the expertise to do it. So for the most part, you should avoid it. Now, also keep in mind, in a lot of jurisdictions, osteopathic practitioners are people with previous training in other healthcare professions, such that they might have licensure and they might already have the information. So additional training from an osteopathic institution may be of lower insight and lower detail, such that it may not necessarily be valuable to those people with previous licensure. So hopefully that doesn't come off as a simple diatribe trying to tell people that they just shouldn't be talking about it. I mean, osteopathic practitioners have every opportunity to educate themselves with respect to nutrition, but they're often not legally in a position to educate the patient with respect to nutrition. So to have maybe a better informed conversation with your patient when they talk about some dietary intervention or when they talk about a diet protocol that they're on, maybe if you understand it, you can have a good conversation with them about it, but you shouldn't be giving them guidance. So hopefully you find that somewhat useful, and we'll talk again soon.